You and the organizations which you all represent are the healthcare system. You are human capital, the human capital who can figure all of this out. So if you can't figure it out, there ain't anybody else that's going to do it. So it's just great to watch you guys and be that fly on the wall as you're having these conversations, which is the segue to our lunchtime panel with Director of Region 10 of the U.S. Department of Health and Human Services, Susan Johnson, and Bruce Goldberg, the Director of the Oregon OHA, Oregon Health Care Administration. The convening panel thought it'd be really interesting if we could be a fly on the wall, if we could listen to some of those conversations that take place between the state and the federal government around how to get Oregon through this hump period, this sort of transition period. How does the state demonstrate its value? How does the federal government hold Oregon accountable? Where does the collaboration look? What does that look like? What is where does the rubber meet the road? So we, in this lunchtime panel, have sort of three segments. And the first segment is, we're just going to put Susan and Bruce on stage and pretend like they're the only people in the room. And let them talk. And have this conversation sort of encapsulate, in many ways, the last few years into a 10 or 15-minute segment. And let's just see how they approach each other. I told them if all they do is smile and nod each other on the back, then I will come up and throw them under the bus. So that you can't do that. And they said that they will be authentic and sincere, and I think that we cannot ask anything more of them than that. Second section of today, I'll just sort of follow up on that. We'll have some quick Q&A, and then we'll turn it over to questions from you about this interaction. We could certainly talk to Bruce, or we could talk to Susan all day long, but I'd encourage you to sort of think about, when you develop your questions, what is interesting about this dynamic, this federal-state dynamic, and how can we learn from their participation in our lunchtime panel to better inform the integration and the transformation and all of the other work that you are doing. So with that, Susan, Bruce, please come up on stage. I'm losing my hair rapidly, as Bruce can appreciate. So I like to sit over here because I think it makes my head look better. And then so you guys can sit
Doesn't matter where I sit. My head's not going to look better anywhere.
But I'm going to give you the stage here for a few minutes, and I'll just let you guys, or Susan can sit there. Yeah, that's fine too. I'll let you guys have the stage.
Hi, Susan. I'm Bruce.
Hi, Bruce. I'm Susan. I got reading material. You didn't.
No, but I'll take some of your water.
Oh, okay. No, that's mine.
So Susan and I were I think we're going to get thrown under the bus by DJ because we actually work very collaboratively together. And I thought I'd start by giving everybody a sense of that because, I've had the privilege of actually working with two federal administrations, the previous one and current one. And they've been really different in a number of ways. One has been in terms of access. Susan and I were going to role play what a phone call was like, but we don't have many phone calls. We leave voicemails, we text each other, we have emails. Susan comes down here, goes to all sorts of meetings. We see each other quite regularly. I'm able to, pick up the telephone and call Cindy Mann or speak with Marilyn Taverner at CMS, which is very different from previously where, quite frankly, it was very difficult for states often to have that kind of collaborative relationship with CMS, much more hierarchical. If I needed to talk with somebody, it would be by getting either Senator Wyden or then Senator Smith to tell Dennis Smith that Oregon wanted to talk to him. And that's literally how it was. And that changed pretty dramatically with the new administration. And I mean, part of that has been trying to create a partnership in how we move forward with health reform. I think part of that has been that clearly from the administration standpoint, health reform has been a big focus of President Obama, and certainly for Governor Kitzhaber, a huge focus. And that's how our relationship really started. By we met, we talked to each other. We invited Susan down to be at many of you were at the series of Wednesday night meetings we had during legislative session. She was on conference calls with work groups and was really able to get a sense of what we were doing and how we were approaching health reform, which quite frankly made it much easier to then deal with CMS. I'm not going to make too much fluff about it, but, dealing with, large federal agencies, often we deal at two levels. And I would say, there's the level at which Susan and I talk, or Cindy Mann, or the governor and the secretary, and Marilyn Tavenner. And then there's a level at which our staff sort of butt heads around regulation, and oftentimes we don't quite understand why there's such a difficulty, and often our roles have been to sort of say, wait a minute, I thought we understood how we were all moving forward. Why are we having such a hard time working this out? And indeed, generally, after a couple of conversations like that, staff get together and work it out. So it's been a really interesting partnership, as I think, we've clearly looked for help from the administration and from HHS in helping us with health reform. It's no secret. We've gotten a lot of help. We've gotten a lot of financial help in terms of a fair amount of investment capital. We've gotten some flexibility in federal rules and regulations. And, we've been asked to perform. We've been asked to deliver. We've got some commitments that we've been asked to make in terms of delivering on a financial return on an investment and on improving quality. And, to me, it's been a very functional and mature and collaborative way of working together that's been refreshing. I don't know, Susan, what about from your standpoint?
Yeah, well, so, in a previous life, I knew your governor when the first list was being circulated, and so it was always interesting to me the real process that Oregon goes through that is intense and requires a great deal of stamina. So when I heard that you were doing these Wednesday evening, I thought, really? Kind of like that Saturday Night Live moment. Really, Bruce? You're going to every Wednesday night? And so I wanted to see how the dynamic of those worked and what sort of unfolded. And that was really revealing that there was a real give and take. There was a candor. There was change. There was receptivity to what people were saying and offering. And then there was buy-in that you could tell after I came back, I think after 6 or 7 weeks and went to another one, how you could actually sense that the process would move forward. So my experience with Oregon has been to tell people in DC, using an Alaska kind of metaphor, this is my lead sled dog team. Let them go. And give them straw when they need it, give them new water when they need it, give them a rest stop when they need it, but let's try to stay out of their way as we can and let them run.
I mean, when you look at certainly us in Washington State, we've got many of the same health and hospital systems. We've got several of the same insurers. We've got a Vancouver marketplace, which is probably more part of the Portland and Oregon healthcare marketplace than I'd venture to say is part of Washington State from certainly a regional perspective in terms of how people travel. You know, the political boundaries are one thing, but the population and healthcare boundaries, in fact, I believe if you look at the Dartmouth Atlas hospital referral districts, you know, Vancouver and Portland are together. So I can see that happening. I think we've got some work to do around how each state regulates its insurance markets, but that is really, I think, A, the discussion for those governors, and B, I think some of the promise of the insurance exchanges, which, you know, at some point we can start to look at regionally. So you can throw us under the bus?
I think that's really good. It's sort of so shocking, really. I mean, I think, honestly, because most federal-state interactions, like the one that you talked about at the beginning of this process, are just not nearly this collaborative, even within the state of Oregon and the federal government on other issues, right? What was it? Was it the governor sort of, you know, making that pitch to Secretary Sebelius, or why is it different in this case?
I don't think you can sell short passion, resolve, tenacity, and the willpower he brought to the fore, or the whole team did. I mean, it wasn't just, hey, we've got this idea, we'd like to see what you think about it. It was like, we have this idea, we're going to do this, we'd like you to partner with us, this is what we have to do, this is the future. You know, I've been in this business a long time, and what do you think? You in it with me? I mean, I think it was this incredible sense of confidence and vision, plus the on-the-ground mechanics, the work that was going to be there, that was a complete package.
Yeah.
I would agree. I think it's about the vision. I think, you know, when you approach it from the bottom up, you get a bottom-up response. And, you know, if you approach it from, well, we'd really like you to change these 6 regulations, you become into a bureaucratic battle. I think when you start to approach it from what are our common goals, I think that's what the governor always tried to come at it from, and as well as the administration. Each, as I started, understanding that health reform, I think the secret ingredient was vision and the fact that health reform was a priority for both administrations, both the state administration and the federal administration. And when they were able to sit down and say, health reform's our priority, we want to make this work for you, I mean, that's what each party understood. We had to make it work for each other. You know, the feds didn't want to see, you know, a Democratic governor go around saying, I can't do what I want to do because the federal government's in my way. And I don't think that, and the administration wants to see states succeed at this. And so therein was a partnership and a common vision for what that meant.
Well, and here we are at one time, you know, back then, launching the Innovation Center, right? With sort of RFPs, if you will, and grants to do pieces. You come to us with the whole puzzle in the box, saying, let us do this. And how? It was irresistible.
Have you been called irresistible much lately, Bruce?
No, that's the first time. I like that.
So how about questions from you all? You know where the microphones are. Please don't be shy and come on up. Let me ask Bruce, as we wait for folks to finish their lunch and come forward, as you're having these conversations with California, Washington, Colorado, other states, if vision is so critically important, you know, Governor Kitzhaber is a third-term governor. He's a special case. You know, got to be one of the top best governors of the last 100 years in the country. That is not, as Susan said, you don't just sort of add water and shake to develop that kind of vision. So how are those conversations going? How do you see I know that you think that the CECO model can be applied in any state, but if vision is so important, where are the roadblocks to other states getting there absent a Governor Kitzhaber?
Well, on one hand, I guess I wouldn't, I wouldn't want to detract from my boss's role in all of this. And certainly, he was a key ingredient. But I think he'd be the first one to tell you that, this wasn't about personality, that in the end, it was about policy. And you need to have a policy champion. And you need to have someone who's going to champion that policy. Can that be a governor? Yeah. Does it have to be? In other states, no. It can be other legislative champions. It can be stakeholder champions. It can be a whole lot of different champions to help move that through. So, I think, I guess what I'm saying is you need a champion. We had a champion. We had a visionary, articulate champion. I'm not so certain, and in fact, when we talk to other governors, some of them say, and they're a little intimidated by an experienced governor who clearly is a health policy expert, and the first thing they say is, hey, I'm not you. How do you do this? And what the governor says is, this is about the policy, it's about finding the champion, and so I think that it can happen in other states. It doesn't necessarily take a governor, but it does take a champion, and it takes a vision, and it takes a policy, and it takes, and I think, Susan, you can't just add water is, I think it also takes a lot of the people in this room. Yeah. And I don't mean that kind of, flippantly or not pandering in any way. I think it takes involvement of a whole lot of people. Yeah. And getting a whole lot of people on board, and a whole lot of people willing to come on board and willing to roll up their sleeves. And we've got that here in Oregon, which is pretty unique and neat.
So, Susan, sometimes the federal government will send these letters that say, oh, excuse me, I didn't see you, ma'am. Why don't you come ask your question?
Hi, I work for a community mental health provider here in Portland, and we're recipients of the SAMHSA PBHCI grant. So we've just started year 2 as of last week, and one of the things that I need to think about is how we can make this sustainable after we are no longer receiving funding from the federal government. So I'm wondering where we are with a conversation around having a behavioral health home designation like other states like Missouri, as that would help to contribute to the financial sustainability.
So let me take that from 2 angles. I'm assuming that's directed at me, not at you.
It's not to me.
One is we are starting. I talked to Pam Martin, our director of addictions and mental health, and beginning to bring together a group to talk about behavioral health homes and how we're going to move that forward. I think more importantly, I guess my sense is, I think we have to be careful about looking at sustainability as how do we have multiple carve-outs. And I think my advice to you around sustainability is to really think about, one, as an organization, how you partner with the CCOs in the area, how you demonstrate value in 2 ways, by doing what we've asked CCOs to do, which is improve health and to help lower costs by doing that. Mm-hmm. And this is what I tell everybody. That's the vision, and that's the ticket for anybody. The ticket for the future is demonstrate value, demonstrate how you can improve health. Anybody in this room that can do that, I think you're sustainable, because I think that's exactly what the healthcare system wants in the future, and what all of us want is Show your value, show how you can, in a real way, improve health, and show us how you can do that at a lower cost. If what you're asking for is sustainability, and this is what I got at from the state saying, how do we get the 1.9 billion? If all you're asking for is 1.9 billion, but you're not willing to deliver on the other parts of that, then you're really not asking for fiscal sustainability. You're asking for a handout, because that's not going to be sustainable. We're not going to sustain a healthcare industry by continuing to just keep paying everybody. So I think that the ticket to fiscal sustainability and sustainability as an organization is really innovating, delivering value, showing all of that. And I think the people that are going to do that are going to have to not worry about fiscal sustainability. You're going to have to worry more about cloning. And how do you clone yourself as an organization?
Does that answer your question?
Yes, thank you.
Great.
So as I was listening to us, I was thinking of a story that I'd like to share. Because as we use these terms, regulator and partner, it's like, yeah, well, what does that mean? You know? And at a certain point in your life, like I am now, I look back and I think, oh, I know that aha moment. So years ago, 40 years ago, I taught school in Vermont, 5th grade. And I was, 20-something, and I was doing this interview for this job, and the superintendent sat down and said, so Susan, tell me what you would do as a teacher in this 5th grade class if you were doing a spelling test and you saw two kids look over on each other's paper during the spelling test. And I thought, no brainer. I said, well, clearly they're cheating. There would be consequences. I'm the regulator, right, in terms of this talk. And so there would be consequences. I'm not sure if they'd have to stay in from recess and write the word 10 times, whatever, 1955 coming into my mind. And the superintendent said to me, well, what if I told you that's absolutely wrong? And I thought, well, I guess I didn't get the job. I blew that. He said, what if I told you that that was their effort to teach each other, and they're doing that because you failed? And that has stuck with me because it made me re-examine how I was seeing my role. I was the cop. I was going to catch them. The underlying thing of why they needed to do that was my failure. Why were they not prepared? So I was just thinking as we use these words, what does regulator mean? What does partner mean? What does it mean to re-examine your role as an administration, as a bureaucracy, or as a state, and call it into question and say, wait, we've evolved from that. And I just wanted to share that story because I think there are times where we get stuck in the past. This is the way we've always done it. This is the way we're going to do it. And this whole evolution in Oregon, I think, opens a lot of doorways to say, well, maybe we don't have to do it that way. We can do it this other way. And that story just popped into my mind.
So Susan, as HHS, and from time to time, CMS will send out notes saying, state, you're doing this wrong, to your point. You're not following your Medicaid plan or whatever. That's underway, as you know, with the mental health system in Washington State. What are the things that you will be what will CMS and HHS be looking for in terms of measuring progress with this transformation project here in the state? Because so much of the heavy lifting is still yet to be done, right? The real integration, moving from fee-for-service to something that pays more innovatively, that all needs to still happen in many cases. And more lawsuits may occur, more frustration may occur. We don't know how that will go. How do you provide that modest partner-like stick to, that nevertheless keeps Oregon, upholds your end of the overall bargain to make sure that you're holding your partner accountable?
Now, we're talking about Oregon now, not Washington.
Yeah, no, I just mentioned Washington.
I don't want to get too confused.
Yeah, there's this small issue in Washington.
I'm trying to figure whether I missed a letter over the last couple days.
You may have a letter on the way. I can neither confirm nor deny. I have no idea. But in the future, you still have to protect those taxpayer dollars of $1.9 billion. You still have to get from Oregon what Oregon has promised in
In the
terms of
time frame.
transformation in the time frame.
Yeah, I mean, it's a lot. I mean, because this was a birthing of 16 entities, you know, that were our toddlers now, in a sense. I mean, they're new, and they're working, and they have to put forth these improvements that then roll up into the state, you know, product that we look at. And so that's a lot of pieces coming together to weave together. But that was the deal, right? That was the deal.
Yeah.
To make these improvements, to save these dollars over time, and we'll front fund that effort to get it going. So, I mean, I think there's the agreement. Then there are the pieces that were mentioned before about you can't take everything away from people. You've got to stay within the confines of the law. But I think what we found here is there's flexibility to encompass that and be creative together.
And I suspect at some point we'll get some letter about something. Because I tell this to folks who work within the health authority. My wife's a family doc, and I always know it's a bad night when I come home and she's got a piece of paper and she's got this look on her face and she says, "Do you know what your agency is doing?" And there's some letter, and it's Oregon Health Authority letterhead. I can't even understand what it says. And she's telling me all the ways that this is going to, she's a very dedicated physician who cares keenly about her patients, and she tells me in no uncertain terms how this is going to interfere with her ability to help her patients. And, you know, I look at it and I go, wow, if that's really what it says, let me go figure it out and go back. And, you know, I ask folks, why are we doing this? And let's try and bring it back to the vision and what we're trying to achieve. And does this help us? And, you know, we work through it. And I think it's going to be the same with the feds.
Yeah.
You know, I anticipate we'll get some letter about something that you won't know about and I won't know about, and we'll figure it out. And I think it keeps coming back to what is it people are trying to achieve, and does whatever the letter about, does it help you or not? If it's about just in being compliant with a regulation that has no real validity, that's not really good. If it's really about helping protect consumers or being certain that we retain fidelity to an agreement, that's okay. But I mean, I think those things are going to happen. I anticipate they do. I mean, we get letters all the time, and we send letters all the time. I think we've got to learn how to do less of that on both ends, us as an agency with our partners and the feds, and we'll get there.
Yeah. So we have about 10 minutes left. Anyone? Don't be shy. I know there are a lot of questions.
Thank you so much for coming and talking with us. I guess my question is more philosophically based. I'm thinking about what you're describing as you're setting a vision and you're being really clear about what the current reality and the systems are. And I'm curious how you know when to time and the timing around how far to stretch that vision in the current reality, or when it's so close that it's kind of boring and you can't, you know, people aren't really going to sign on. So it's kind of a comment and a question. How do you set timing? And then my second question is, how are you thinking about using the CCOs and the learning in that environment with the other payers and the other sort of health reform movement as a whole?
And just by way of introduction, Brenda, your organization?
Sorry, I'm Brenda Johnson. I serve as the director of La Clinica, which is a community health center in Southern Oregon. And I also have a great privilege of serving as a board president of one of our local coordinated care organizations.
Hey, good to see you, Brenda.
Hi, Bruce.
You know, your first question is one that keeps me up a lot at night. You know, it's a question of how fast do we push, and when do you push more, and when do you not? And I don't know. You know, we're in this time, and every day I sort of go through my head, we've got so much to do, and we all know it. I see it all the time. You see it. There's so much work to get done. When is it that we need to push more and expect more from ourselves? And when is it that we understand that we've got to pace ourselves and be strategic about how we make that change? And I don't know. I think it's hard, and I think we've got to have that push and pull at all levels. I know, I get that. The governor will say, how come we haven't done this yet? Or how come we can't be here yet? Or I'd like you to do this by next week. And I'll go, next week? This is going to take a year. He says, well, okay, 2 weeks. Well, 6 months. Okay, how about a month? 3 months. Okay, you think you can do it in 2 months? Yeah, we'll do it in 2 months. But I don't know a good answer to that, other than I think that's probably a really good tension, and we should continue to have that. So in terms of extending what we've done around coordinated care organizations, our whole notion has been that now is the time. We've had a year under our belt. We've seen successes. It's time to start extending this model out into public employees, Oregon educators, and on to the insurance exchange and the qualified health plans. Like the first part, it can't happen either too quick or too slow. What we're looking to do is we just put an RFP out for PEB. It really looks at how are we going to purchase, in essence, the same things that we're doing in Medicaid. How can we get a rate of growth that approaches 3.4%, have similar quality metrics, create some of the same expectations around primary care, and we're hoping that there'll be a lot of people that want to do that. We all use the same healthcare system. We see the same doctors. We get cared for in the same hospitals, whether we're in Medicaid or whether we're in a public employee. I'm a public employee. I get care in the same place some Medicaid recipients do. So there, we want to extend the model. The PEB RFP just hit the streets. We're really encouraging all sorts of organizations to do that and apply. And we had a number of CCOs are on the exchange in several regions. And so we think that that's going to evolve. We hope it evolves. Probably will be too slow for some and not quick enough for others. But it continues to get back to the principles of sustainable rate of growth, adherence to quality and health improvement, payments based on that, changing how you pay, moving towards better primary care, prevention, alternative payment methods, and I think that's what you're just going to continue to see and evolve.
Thank you. Thanks.
So we've got just about a minute and a half or so left here before I know people want to break and stretch their legs. Bruce, I want to ask this question, which is an hour-long question, but I'll give you a minute and a half or so. I have heard today and at dinner that, a dinner last night, we have a dinner the evening before. Heard a lot about the value of the prioritized list in Medicaid and in the CCO world. And while the commercial marketplace is not Medicaid and Cover Oregon is not OHA, what do you think about the notion of bringing that prioritized list into, that central element of Medicaid and the CCOs into the commercial exchange world? Is that reasonable, or is it maybe a stretch to think about doing that?
I think that we've got to think about it as why we started the list. And I think we started the list because we understood that there's some healthcare that is of greater value and greater efficacy than others. I mean, and that there are differences in effectiveness, and that we need to prioritize that. I think that's really consistent with where we're moving in terms of healthcare being evidence-based, value-based, that it really is about our ability to get an outcome with within a budget. So I think that the list as a principle around evidence-based care and value-based care and effectiveness is very applicable. In fact, every insurer in the room, and those that even aren't in the room, does the same thing. They all have their internal medical reviews and ways that they judge medical necessity and effectiveness. And I think ultimately we're only going to succeed if we all do that together. That we all look at the same evidence, we look at how collectively we make decisions about what's effective, what's not effective, what's a priority. And we do the same thing around quality and outcome metrics. That we stop having 100 different, everybody has their own flavor on how to best know whether you're delivering good care with diabetics or whatever. So I think the more we can align all of this, the better. I don't know exactly how. I don't think we're going to impose a prioritized list, but I think it gets back to why are we doing this? How do we bring some consistency? We're all, I mean, you talk to any doctor in this state or in any hospital, they all taking care of the same people that are being covered by all these different silos of rules. And at some point, I think the vision is how we bring that together. I think we can do that around the list. I think it may not be about, here's where you draw a line, but it is about how you have a common understanding of what's effective and what's a priority, and how we're going to rank things, and where the value is. I think that's a noble and a good conversation for our entire healthcare system to have, and I think that's what everybody wants us to have.
Let's give them a round of applause. Thank you very much.
Pleasure.
Yeah, no, I appreciate that.